Good afternoon, everyone. Thanks so much for joining this webinar that's organized by Diabetes Canada. I'm Ariane Gabou, and I'm happy to host with Grace today this webinar. And we propose, I think, a subject that could be very interesting. The title is What You Always Wanted to Know About Diabetes in Pregnancy, but We're Afraid to Ask. The session is recorded, so you're going to be able to view or review it later. Feel free to type your question in the Q&A box, in the Q&A little icons on Zoom as long as the talk go on. However, we're going to answer them at the end of the talk. We're going to have about a 10-minute Q&A session after Denise talk. So to give this talk, we are very fortunate to welcome today Professor Denise Feig as our invited speaker. Dr. Feig is currently one of the international leaders on the topic of diabetes in pregnancy. She's head of the Diabetes in Pregnancy program at Mount Sinai Hospital and University Health Network. She's also professor at the University of Toronto in the Department of Medicine and has a master's degree in clinical epidemiology. She's also the past chair of the ADA Pregnancy Planning Committee, one of the past chair of our CANDIP study group, and sits on the International Diabetes and Pregnancy Study Group. She participates in the recent CDA clinical practice guidelines by nicely leading the group to write the chapter on diabetes and pregnancy. She has numerous grants and publications in the area of diabetes and pregnancy and was PI of co-PI of very important recent research in the field, like the MIGHTY and the CONCEPT trial. And to finish, above all, Denise is a very welcoming person, very generous of her time and teaching. She's an inspiring model for many of us. So we are very, very grateful that you accepted to give the talk today. Before letting Denise talk, Grace will have some quick questions for you that you will be able to answer directly from Zoom. Gonna have a little window pop up that you can just answer if you could please. And this is just to have a glimpse of the audience today. So please, Grace.
Thank you. So yeah, we just want to get a sense of who's in the audience today. So thank you all for joining. So I'm just gonna launch the first question. We just want to know your profession. The poll should have just popped up. We'll give you about 20 to 25 seconds, and then we'll see who our attendees are today. Okay, great. So most of our attendees, actually 43%, are registered dietitians today. We have 20% registered nurses. We have a pharmacist, some endocrinologists, 13% of our audience endocrinologists, a couple of family physicians, general practitioners, a student, and of course, I can never figure out how to encapsulate all the others because every time we have some others, so 10% are other. So that's great. I am going to stop sharing this one and we'll do just one more question. We just want to know where you're watching from today. Great. So as per usual, about 50% of our audience is in Ontario. I think that's normally just because of the time we're doing the presentation. But I do love to see, in pretty much all of our presentations that we've done, all of our webinars, we typically have representation from all over the country. So pretty much coast to coast here today is represented. So that's great. And I won't do Denise's introduction. I won't go over credentials again because we'd run out of time. So I'll just, without further ado, pass over to Denise.
Okay. How do I get to my slide?
I think, yeah, there we go.
All right. How do I get rid of the poll?
So just the poll should have stopped sharing. Yeah, and then you should be good to go.
It hasn't stopped sharing.
You should be able to exit, like click the X in the top right corner of the poll that's in front of you.
I know I'm trying to, but can't see my, oh, there it is. Okay. Okay, great. So welcome today. I'm glad you all tuned in for this talk. I wonder if you've had this experience where you've had a patient who's doing so well, their A1C is under 6.5%, they're working so hard, and then they go to the obstetrician and come back and tell you, my baby's over the 90th percentile. And she's frustrated and we're frustrated and we're all disappointed. And we're saying, how can this be? You're doing so well. So today I want to address the question, why are the rates of LGA still so high despite all our efforts? And these are some of the topics I'm going to discuss. Are we missing hyperglycemia? Is HbA1c reliable in pregnancy? Is timing of hyperglycemia important? What about time and target? Is that better? What about glucose variability? Should we consider maternal obesity and maternal weight gain? What about the diet? Is that important? And finally, does technology improve LGA during pregnancy? Sorry. Okay. So what are the rates of LGA, first of all? As you can see from, I've just put up a few of the studies that I found. The rates of LGA are the highest in women with type 1, between 46 and 69%. Very, very high rates of LGA. Type 2 is second, a little bit lower, but still pretty high, between 24 and 38%. And GDM is lower, but it is above the average, between 11 and 13%. What's happened to the LGA rates over time? Well, this is a national study looking at trends over a 15-year period between 1998 and 2013 in Scotland. They included over 3,000 women with type 1, 1,500 women with type 2, and 800,000 women without diabetes. The top line are women with type 1, and the bottom are women with type 2. And this is the prevalence of diabetes in their population over time. And surprisingly, type 1 did increase by 44% over this period, but not surprising, type 2 increased by 90%, so almost doubled, which is very similar to what we have found in Ontario. What about the birth weight Z-scores? The birth weight Z-score increased in the type 1s and kind of increased, but up and down in the type 2s, and slightly increased in the non-diabetic mothers. So the weights are increasing. Now, what are the contributing factors to LGA? And these are some of the factors I'm going to discuss. We all know that hyperglycemia crosses the placenta, leading to an increase in fetal insulin and therefore excess fetal growth. It's possible that glycemic variability can also play a role. We believe excess maternal weight gain and maternal obesity may also be playing a role, and I'm going to discuss all these over the course of the talk. Let's talk about hyperglycemia first. We all use hemoglobin A1C to measure glycemic control both outside of pregnancy and in pregnancy. But as you know, hemoglobin A1C isn't perfect. It measures hemoglobin glycation from exposure to glucose over the lifespan of the red blood cell, which is 120 days. And anything that affects the lifespan of the red blood cell or the production of the red blood cell can affect the hemoglobin A1C without actually reflecting glucose concentrations. And this is true outside of pregnancy. So what reduces the age of the red blood cell and therefore falsely lowers A1C? Well, we know that hemolytic anemias and thalassemias, hemodialysis, chronic kidney disease, erythropoietin therapy, blood loss, and transfusions all falsely lower the A1C. Things that increase the age of the red blood cell and falsely elevate the A1C are anemias from deficiencies of iron, folate, B12, and in pregnancy, we often see anemia from iron, failure to clear cells such as asplenia, and chemical changes such as high-dose aspirin and renal failure. So you can see renal failure can both cause a falsely low and a falsely high A1C. And the doses that are referred to here are much higher than the doses of aspirin that we use for preeclampsia. So what about pregnancy? What does A1C do in pregnancy? And I'm just going to show you a slide from our concept trial, just to mention the concept was a randomized trial of women with type 1 who were randomized to receive CGM or standard care. And our primary outcome was a change in hemoglobin A1C. And here in this graph is our A1C at 3 time points, baseline 24 and 34 weeks. And the CGM group is in red and the control group is in black. As you can see, both groups decreased markedly at 24 weeks their A1C, suggesting that the glycemic control improved greatly by 24 weeks. But is that really true? When we look at the time in target, and this is CGM percent time in target between 3.5 and 7.8 at baseline 24 weeks and 34 weeks, and the green is the control group or HGM group, like the monitoring group, and the blue is the CGM group, you can see between baseline and 24 weeks, the HGM group doesn't move at all, and the CGM group goes up just very little, meaning very slight improvement. So actually that glycemic control didn't change very much. And what's happening with the A1C is that there's an increase in red blood cell turnover, so the hemoglobin A1C drops markedly, but not because of glycemic changes. Then you can see that both groups go up slightly at 34 weeks. Does that mean that glycemic control worsens by 34 weeks? Well, no, it doesn't actually. When we look at the time and target at 34 weeks, both the HGM and CGM groups improve markedly their time in range. So there is a disconnect between the A1C and the time in target, and probably the time in target is much more reflective of what's happening. But I'm not going to say that the A1C is useless during pregnancy. Many, many studies have shown that A1C does predict congenital anomalies, LGA, stillbirth, many adverse outcomes. But maybe it's not sensitive enough for more minute changes. And are we missing hyperglycemia with hemoglobin A1C? This is a study by Eleanor Scott at the University of Leeds in the UK. And she pioneered what's called functional data analysis, where you take all the little CGM measures and you extract a shape information from them. So you can see temporal trends in the glucoses, and then you can compare populations. She asked the question, can functional data analysis on CGM data help us understand why we are still getting big babies despite having seemingly normal glucose control on finger prick testing and A1C? She looked at data from 117 pregnancies, a total of 1.7 million glucose measurements. In their population, 46% of pregnancies were LGA, and there was actually no significant difference in A1C. As you can see, the A1C in the LGA mothers was just a touch higher, 6.4% compared to the no LGA of 6.2%. Was not statistically significantly different. But if you looked at the functional data analysis comparing the LGA mothers to the non-LGA mothers, and the LGA mothers are significantly different than the non-LGA mothers if they don't cross the 0 line, you can see that the LGA mothers, were higher than the non-LGA mothers, both between like 0 and 4 a.m. and between noon and 4 p.m. So there were areas where, in fact, the LGA mothers were higher in their glucose levels. And that was trimester 2, and trimester 3 was mainly in the evening, which suggests that in the later stages of pregnancy, glucose control during the evening or night is suboptimal and contributes to fetal growth, something yet that you could not see in the hemoglobin A1C values. Now, what level of A1C do we want in pregnancy? It may surprise you, but normal A1C in the 3rd trimester is closer to 4 to 5%. And in some studies of type 1 diabetes, women who get A1Cs above 6% are associated with LGA by the 3rd trimester. And another study showed that women with an A1C under 5.5% had a markedly lower LGA rate than those above 6.4, but it was still a little bit high. It was 19% versus 52% above 6.4. So you can see that we're not getting even close to normal values, and this is probably contributing to LGA. Now, can we use HbA1c for screening for type 2 or for GDM? Well, the CDA does, or Diabetes Canada does recommend screening for type 2 diabetes at the first prenatal visit in those you suspect that may have type 2, and considering a hemoglobin A1C of greater than or equal to 6.5%, possible or presumed type 2 diabetes, we should treat them as type 2 and confirm postpartum. But we know because the A1C drops so quickly in pregnancy and not due to glucose measures, but it still drops, it's not that sensitive for diabetes. So you might miss people, but it is very specific. So if we find an A1C over 6.5% at the beginning of pregnancy, you are likely to have type 2. Now, at the beginning of pregnancy, one study from Australia noted that an A1C of over 5.9% diagnosed all the diabetic women, so it's very sensitive, but not specific. So some will not have diabetes. Now, 5.9 to 6.4 is kind of like IGT. And they found that these women had poorer pregnancy outcomes when they were not treated throughout pregnancy. So even in the CDA guidelines, we say that you can consider treating these women during pregnancy who have an A1C at the beginning of pregnancy from between 5.9 and 6.4. But we really don't know the exact threshold for diagnosing GDM per se in early pregnancy using an A1C or even OGTT results. So more studies need to be done on that. What about using A1C at 24 weeks? We know an A1C is not sensitive to diagnose GDM. But for COVID screening, we are recommending treating A1Cs of greater than or equal to 5.7. We know it only captures about 25% of all women with GDM, but because in the height of the COVID, we were worried for women going to the lab, we were worried for staff coming in to treat women. So we wanted to treat only those who really needed treatment, and that's how we came up with these screening guidelines. Now, what about time in range? Does it reflect LGA? The theoretical advantages of time in range, it's reflects direct fetal exposure to maternal glucose and not subject to gestational physiology. Now, this is an article where a committee got together and decided on the clinical targets for time in range outside of pregnancy and during pregnancy. As you can see, in type 1 diabetes, they suggested a target range of 3.5 to 7.8, greater than 70% time in range, less than 25% above time in range, and less than 4% below time in range. And this was based on our concept trial results, which showed that around 70% time in range was associated with improved neonatal outcomes. As you can see, there's no numbers here on gestational and type 2 diabetes, and that's because we have very little data. But it's likely that we need or want a higher time in range. And I'll just show you, this is a study by Helen Murphy done some time ago, and I just want you to look at the top left-hand corner, the A block, And this is time in range. The green is type 1 diabetes and the red is type 2 diabetes. And as you can see, by 36 weeks, the type 2 diabetic women do reach, on average, about 80% time in range. So they are doing better, and we probably will recommend more time in range for them, but we need more data. So is time in range associated with LGA? This is a real-world data study from Sweden, where they looked at 186 women with type 1, and in Sweden, CGM is paid for by the government during pregnancy, and women were allowed to pick if they wanted real-time CGM or iCGM, which is intermittent CGM, which is basically the Flash Libre. About half chose RT-CGM and half iCGM. They found that 5 to 7% lower time in range in the second and third trimester was indeed associated with LGA and adverse neonatal outcomes. And this was similar to the concept trial. So the good news is you can tell your patients if you achieve a 5% improvement in your time in range, you should be able to see some improvements in neonatal outcomes. What about GDMs? What evidence do we have for them? In this study by Eleanor Scott, they looked prospectively at 162 women with GDM. They wore a masked CGM where they couldn't see the numbers for 7 days at 30 to 32 weeks, and they correlated the glucose values with LGA. So they found no difference. Now here, what we can see are two groups: the mothers who had LGA infants and the mothers who had normal size infants. And what you can see is on the bottom, the fasting glucose was actually not different in the two groups. The time in range and time below range were not different. The time above range was higher in the LGA group, but didn't quite meet significance. What was different was the mean glucose was higher in the LGA group, 6.2 versus 5.8. And although the daytime was higher, it didn't quite meet significance, but the nocturnal glucose, again, was significantly higher. So here we have, again, the importance in GDM women of nocturnal hyperglycemia causing fetal overgrowth. But it's fascinating that you could not tell from the fasting glucose that they were actually very different. Are women achieving this time in range? So we're asking women to achieve a 70% time in range. Are they achieving it? Well, in the concept trial, if you look at the top time in range, the mean time in range was 68% overall. And in the Swedish study, which is a real world study and not a trial, they achieved a little bit less, 60% time in range. But I'm going to show you something surprising. This is unpublished data from the concept trial. And if you concentrate on the middle, where we're looking at time in range, we're looking at the percent of women that actually achieved the time in range, not the mean time in range achieved. So in the first trimester, only 9.1% achieve a time in range of over 70%. In the second trimester, only 11%. And in the third trimester, overall, only 37% achieve a time in range of over 70%. And if you look at the red of RT-CGM, it's a little bit better at 46%, but it's still only half. So what do we learn from this? I think we learned from this that we're not doing what we're asking people to do, so we really need to try to get more women to a target of over 70%, and we need to get it done sooner in the pregnancy. What about glucose variability? Well, several studies have shown that both an increase in glucose and an increase in glucose variability independently are associated with LGA. But the truth is that they both tend to go hand in hand. And if you try to improve glucose, you're usually improving glucose variability and vice versa. So it's a little bit hard to tease them apart, but certainly both may be important. Now, macrosomia in this study was associated with hyperglycemia, but the predictive capacity, it explained only It explained only 5% of the variance. So there's a lot more explaining why we have macrosomia. So what else could explain it? Well, first of all, maternal obesity. We know that even in non-diabetic women, pre-pregnancy obesity is associated with fetal overgrowth. But what I personally did not realize was that our women who are pregnant with type 1 diabetes, their rate of overweight and obesity is 45% higher than the non-diabetic pregnant women. Now, I realized that our type 1 who used to be all lean are getting more overweight, just like the general population, but I did not realize that they were higher in overweight and obesity. And what we do see in research is that this does matter. Both obesity and hyperglycemia are independent risk factors for LGA in our women with diabetes. And if you have both, it is additive. Gestational weight gain is beginning to also be an important factor in LGA, and it is independent of glycemic control in our women with diabetes. Now here's a question poll that I'd like people to answer. Does the diet during pregnancy affect offspring adiposity? Number 1 is yes, number 2 is no, and number 3 is maybe. So if you could all vote, that would be great. Okay. Oh, yeah, good. Okay. So does diet affect offspring adiposity? 74% said yes, 3% said no, and 24% said maybe. Okay. And okay, so what does the research show? This is a sub-study of our concept trial where in the UK, Helen Murphy, who is a co-principal investigator with me on the concept trial, asked all her UK women to do a 3-day food record at the beginning, at the end, and at the end of the trial. And what did she find? She found that the intake of carbs were consistent with guidelines. So our women with type 1 diabetes are eating the right amount of carbs. However, half of them were from non-recommended sources, confectionery, biscuits, and cakes. Could be the tea time at the UK. I don't know, when they're eating all these biscuits and cakes. She also found that the fat intake exceeded recommendations. And I think this is very common in our women. We're trying to avoid carbohydrates, so we're increasing the fat. And this may have a detrimental effect on offspring adiposity. It's been shown in animals that dietary fat promotes offspring obesity, liver fat, and metabolic syndrome. And it's been shown in humans that maternal lipids, triglycerides, and free fatty acids are independent predictors of fetal growth. Because of this, Terry Hernandez did a randomized trial. Now, this study is not yet published, but it was presented as an oral presentation at the ADA in June. So they asked the question, does a high carb but low fat diet that they call the choice diet, which was 60% carbohydrate and 25% fat, lead to reduced fetal adiposity in GDM women compared to a low carbohydrate and high fat diet, which is standard 40% carbohydrate and 45% fat? They found that the choice diet, the low fat, high carb diet, led to lower area under the curve for glucose after breakfast, higher insulin levels but improved insulin resistance, and lower postprandial free fatty acid levels. However, this did not translate to a difference in neonatal adiposity, unfortunately. Hopefully, we will get more answers when we see the full publication. Next, I'd like to answer the following question. Does technology improve LGA during pregnancy? I'll start with continuous glucose monitoring and our trial, the CONCEPT trial. As I said, we randomized women with type 1 diabetes to receive CGM or standard care. And I've shown you this slide. And we found that the women using the CGM had a significantly greater reduction in A1C than the control group by 0.2%. So a small percentage different, but significantly different. We found that the time in range was significantly higher and the time above range significantly lower in our CGM group. The time below range was similar, and both pump and MDI users benefited from the CGM. What about neonatal outcomes? Did it translate into neonatal outcomes? We did find lower LGA rates, lower hypoglycemia rates, and lower NICU rates above 24 hours. And the numbers needed to treat to prevent one adverse outcome was very small, 6 to 8 women needed to be treated. We also found a 1-day reduction in hospitalization of the infants. Now, we all know that CGM is expensive. So is it cost effective to use CGM? In this study by Helen Murphy in the UK, they looked at this question. And despite the cost of CGM being significantly greater than finger pricking, you can see CGM is 1,820 costs 1,820 pounds per pregnancy compared to 588 pounds for SMBG. When they factor in the cost of CGM by the government paying a slightly reduced cost and the very high costs of NICU, the government actually ends up saving 9 million pounds per year. So it is definitely cost saving for the government. Because of this, the government of the UK is now paying for real-time CGM in all women with type 1 diabetes in pregnancy. And this is being done in other countries too, in Sweden, in Denmark, in Australia. And we have just finished a cost-effectiveness study in Canada and hopefully that will come out soon. What about the evidence of CGM in GDMs? Well, there's very little evidence. There's been 3 RCTs of only intermittent blinded or masked CGM. The biggest one was from China, where they did intermittent CGM every 2 to 4 weeks, and they did show lower birth weight, preeclampsia, and C-section. Glucomoms did it only every 6 weeks and showed no difference in LGA, and a smaller RCT doing it only 3 times in the pregnancy showed some improvement in A1C, but these were all masked, and I think what we really need is an RCT of real-time CGM or iCGM in pregnancy in our women with GDM. And I think there are researchers doing this now. What do we know about the use of iCGM or intermittent CGM, which is the flat freestyle Libre, compared to the RT CGM? Well, there's no randomized trial comparing the two at the present time, but there is some cohort studies. So we know that real-time, this is the real-time Medtronic, Dexcom, and this is the iCGM, called intermittent CGM because you have to scan in order to see the result. So both of them we know track glucose in real time, allow monitoring of time in range, both show how the glucose is trending, but only the real-time CGM alerts of actual or impending highs or lows. So is the iCGM accurate in pregnancy? This study done by Eleanor Scott had both type 1s, type 2s, and GDMs, and they had them wear the freestyle sensor and at the same time as doing finger pricks, and the accuracy zone A, which is the most accurate, 88% of the values were in zone A, which is quite good. When they looked at the overall MARD, it was 11.8%, which is very similar to the MARD found outside of pregnancy. This compares to the MARDs outside of pregnancy in the Dexcom, which is 9%, and the Medtronic MiniMed, which is 8.7%. So in general, the MARD of the Freestyle is not as accurate as the other sensors, and this is true both in pregnancy and outside of pregnancy. The problem with this study is they don't report the PC blood sugars, which we really depend on in pregnancy, which of course are the rapidly changing blood sugars, and they don't report the blood sugars under 4 alone, which is also important. In a letter to the editor, this researcher reported on one woman who was using sensors and doing self-blood glucose monitoring, and they calculated the MARD and the accuracy in this woman, and they found that the accuracy was actually better in the 3rd trimester, not a bad MARD, Freestyle of 7%, and the accuracy was worse at 1 hour PC, which is understandable, but the MARD was about 10%, which was not terribly bad either. Now, in this tips from the UK on the use of the Freestyle, they recommend doing finger sticks when you do have insulin dose decisions, when you're hypoglycemic, and when you're monitoring recovery because of the delay in the sensor reading, and if the sensor reading doesn't match how you feel. And it also tells you it's less reliable during the first 24 hours, during times of rapidly changing glucose, and during moderate activity. But interestingly, these are very similar to the recommendations for the Dexcom, and the only difference was they do not necessarily recommend you doing a finger prick when you need to take insulin, make insulin decisions. So they're very similar. Now, I'm showing you again the data from the Swedish real-world data study, because they compared the time CGM measures in the RT-CGM group and the intermittent CGM group, or the Freestyle group. So here you can see in white is the real-time, the mean real-time numbers by gestational age, and the black are the iCGM group. As you can see in both groups, the time in range starts pretty low, about 40%, and goes up slowly to 36 weeks, where it's up to around 70%, where we would like it. And the good news is there was no significant difference between the RT-CGM and iCGM in time and range. Here you can see time above target, and it starts out higher than we would want and comes down through pregnancy, and there's no significant difference, again, with the, between the RT-CGM and iCGM groups. Where there was a difference, however, was the time below range. You can see in black the iCGM has a higher time below range than the real-time CGM. And what we don't know is are these true hypoglycemia because we're not getting alerts from the iCGM? Or is this simply because the iCGM tends to read lower? And we often tell our patients using iCGM, you know, if it shows low and you don't feel it, make sure that you check a finger prick. Now we do that with RT-CGM too, but especially with the iCGM. So we don't really know if this is because of true hypoglycemia. Now, when they compared maternal and neonatal outcomes, they found that there was no difference in the outcomes, which is fairly reassuring. But just remember, this is a cohort study, and to really know if the iCGM is non-inferior to real time, we would need adequately powered RCT. The good news is that the iCGM, I think the Freestyle Libre is planning to add alerts to their CGM and to make it more accurate, but I hope that the price point remains low. Now, what about pump use? Does pump use improve LGA in our patients? Now, here's another poll for you. I'm going to ask the audience to vote. Do pump users do better than MDI users in pregnancy? 1 is yes, 2 is no, they do the same, and 3 is the pump users do worse. So please vote. Okay. Okay. So it's about equal. 43% say yes, pump users do better. 49% say no, they do the same. And only 9% say pump users do worse. Well, let's see what the research shows us. Okay. Here I have the 5 randomized trials that randomized women to pump use versus MDI, and they all showed no difference. But as you can see, they were all in the 80s, and since then, of course, pumps have changed dramatically. So I don't think we can really get too much from these trials. Since then, there have been actually no randomized trials, just cohort studies. And there was a recent meta-analysis, which I'm going to show you, of both the randomized trials and the cohort studies. They included 47 studies, 2,600 women on pumps, and 5,000 women using MDI. They found that the pump users had better glycemic control in the first trimester, but it was the same by the third trimester. Pump users used lower insulin doses, but pump users had greater weight gain and increased LGA. Wait a minute, those are bad. That's surprising. Let's see what else the research shows. This was a sub-analysis of our concept trial where we looked at our pump users versus MDI users. Just bear in mind that women were not randomized to pump use, they chose pump use. So this was just a cohort study using data from the concept trial. What did we find? We found that pump users had less of a decrease in A1C and less women were reaching their goal of A1C under 6.5%, less women. We also found that at 24 weeks, the pump users showed 5% less time in range and 6% more time above range. But by 24 weeks, they were the same. We found that pump users had more gestational hypertension, more NICU admission over 24 hours, and more neonatal hypoglycemia. So worse outcomes. So why is that? Is it all due to the poor glycemic control at 24 weeks? And why would they have poor glycemic control at 24 weeks? Is it because they have less restricted diets? We often tell pump users, well, you know, just eat whatever you want. It doesn't matter. You can bolus, just match your carbs, you'll be fine. Is it because our pump users have less insulin adjustments because it's more complex? Is it because of worse absorption with the pump? Although you would have expected that by the third trimester, it still would be worse absorption. Is it because of the people who choose pumps? In Canada, the people who choose pumps tend to be the best patients. In the UK, they tend to be the more challenging patients. Well, we went back and looked at the dietary patterns of our pump users versus our MDI users. Just one sec. Oh, I forgot to start my time. Anyways, we found no differences in the intake of carbohydrates, protein, fat, or fiber. The average daily carbs was 190 to 200 grams with similar distribution between meals and snacks and similar intake of recommended and non-recommended carbohydrates. So it wasn't the answer that they were eating more poorly. As you all know, insulin requirements really change in that second trimester. And in a study by Elizabeth Matheson in Denmark, she showed that the basal changes increase by 50%, but the bolus increases by 400%. And my theory is that our women are more comfortable changing their basal, but not comfortable changing their bolus. And since our study, I've asked many of my patients and I've found very similar answers. And what I'm trying to do is educate our patients, one, to be much more aggressive in the second trimester when they see the high sugars, and two, if they're not comfortable changing the bolus on their own, to just add 1 or 2 units to whatever the pump says, and then we can change the ratio when I see them. Now, what about hybrid closed loop? The 670G is available now in Canada. And I'm sure you've had women with type 1 who either get pregnant on the 670G or want to get pregnant on the 670G. Well, what do we know about hybrid closed loop in pregnancy? This was the first hybrid closed loop used in pregnancy. It was from Cambridge, from Helen Murphy's group, and it was pretty clunky. There was a continuous glucose meter there talking to this big tablet that they had to carry around, and then this talked to the insulin pump to tell the pump how much to give. Lucky it's not so clunky, but in that study, they compared about 10 women, and they randomized the women just overnight to closed loop versus sensor augmented pump. And they did find more time in range in women using the closed loop overnight. And then they said to the women, well, now you can just use it daytime and nighttime if you want for the rest of the pregnancy, and they did. And they found a reduced time in target. Why would that be? Well, as you can see here, this represents times of day, and the orange represents the closed loop, and the gray represents the sensor augmented pump. And as you can see, the closed loop is definitely better overnight than the sensor augmented pump, but it's exactly the same as the sensor augmented pump during the day. And the reason is because the women still have to count their carbs and bolus for the meals, and the closed loop algorithms are unable to fix the mismatches postprandial of hyperglycemia. So how can we improve postprandial hyperglycemia? And we, even without closed loop, we all struggle with this a little bit. Well, first of all, we ask our patients to be more meticulous, to pay more meticulous attention to the meals and the snacks, and to pay more attention to count the carbohydrates and use less simple sugars. We encourage more aggressive changes to the bolus doses in the 2nd and 3rd trimester. We ask them to pre-bolus, and often they're pre-bolusing at the beginning by 15 minutes before the meal, but by the end, they're pre-bolusing 30 to 45 minutes. And that's because as the pregnancy goes along, it takes longer and longer for the insulin to be absorbed. And if you don't pre-bolus, what you get is the food absorbing first with a high postprandial glucose, and then the insulin absorbing where you get a postprandial low, actually. And of course, we need better algorithms to mop up any mistakes or mismatches that we have when we estimate our carbs. There are 2 ongoing randomized trials of closed loop in pregnancy, one by Polsky, who's doing a pilot study with the 670G that aims for 6.7. Now, the problem is that we aim for a fasting of 5.3, but her theory is that some women struggle so that the mean glucose overall will probably be better using the 670G, and we'll see if she's right. Dr. Murphy is doing a larger RCT of 150 women using the Cambridge algorithm, where they're aiming for 5.5 in early pregnancy and 5.0 from 20 weeks on. And this is closer to pregnancy algorithm, and this should be very interesting. So far, Dr. Polsky reported 3 cases of off-label use of 670G. The good news is that they had no serious adverse events. And I'm just going to describe the 2 cases to show you what I kind of got out of these cases. The first one started in the 2nd trimester, and she started because her average glucose was above what we would want, 7.4, and she had a lot of glucose variability going from hypo to rebound hyper all the time. After she started auto mode, her average glucose went down to 7, and in the 3rd trimester went down to 6.8. So that's quite good. Maybe it would have anyways without the auto mode, we don't know, but that's what it showed. Another interesting thing is that often in auto mode, it doesn't let you do corrections whenever you want to. And she used fake carbs to do corrections when it wouldn't allow her to. About 5% of her boluses were from fake carbs. She also changed the active insulin, and I often change the active insulin in my pumps down to from 4 hours to 3 hours. But interestingly, they changed it down to 2 hours and 15 minutes, which is quite short. The patient stayed on auto mode during labor and did fine. And even postpartum, she didn't need to add carbohydrates with breastfeeding. And the second case basically was a case of a woman who was doing very poorly and mostly non-compliant. She started the 670G 2 months prior with an A1C of 11 and going into pregnancy with an A1C of 9. She didn't spend the majority of time in auto mode in the first trimester, only 69%, and her average glucose was 9. But by the third trimester, she spent 86% of the time in auto mode, and it went down to 7.9. So basically the message is, here's someone who was doing very poorly and probably did do overall better, but she had to be coaxed into using the auto mode, because even when she doesn't use it, she didn't benefit from it. This is her glucose on the left before auto mode with wide swings, and on the right after auto mode. So in summary, what can we do to reduce LGA? First of all, there are several modifiable factors. Hyperglycemia, I think we should at least try to aim for under 6% and a mean glucose under or equal to 6. Reduce glucose variability. You know, if we can, aim for normal weight pre-pregnancy and pay attention to the weight gain during pregnancy. What about diet? Well, women with type 1 eat more fat than recommended, which may be playing a role, so we can certainly look at that. But we do need more data on a low carb, high fat versus high fat, low carb diets and see if fat is really affecting LGA. I think we're likely missing some hyperglycemia with A1C, so I think time in range is very important. It's been shown that real-time CGM is effective in reducing and improving outcomes in women with type 1, and you can just tell your patients just a 5% increase in time in range will help. The international consensus states that we should aim for 70% time in range, but we're not really doing that for most patients. We should try to do that and try to do it earlier in the pregnancy. iCGM is clearly not as accurate as the current real-time CGMs, but it may be just as good in practice. I think it's really, for type 1s, a financial issue. I do recommend real-time CGM in type 1s, especially in those with hypoglycemia unawareness. But if they can't afford it, I do believe that it's probably better than just self-blood glucose monitoring. Type 2s, we don't have data on type 2s, but I do have some women using CGM. I think it's likely to be beneficial, but we don't know for sure. Our GDMs, we don't know if it's beneficial, and we do need RCTs. I do have a few that really would not be doing self-blood glucose monitoring without the flash glucose, and I say, well, having glucoses is better than nothing, so go ahead and use it, and they find it's helpful. Pumps users do not seem to be doing as good as MDI users, but I personally think it's more of an education issue, and I'd be interested to hear your thoughts. And so I'm really trying to get our pump users to make better choices, especially and more aggressive choices in the second trimester. I think closed loop is promising, but we do need more data and more pregnancy-oriented closed loops. And we need to find ways all around to improve postprandial highs. Thank you.
Thanks so much, Denise. Very instructive. I will let people just type in their question. I can start with a quick one. Just going back to the study that compared the choice diet and the standard diet with the high fat and high carbs. Do they need more insulin, ladies, when they have the choice diet? Like, do they report?
Yes, they reported because of the higher carbs, they did need more insulin. But interestingly, the insulin resistance was lower.
Yeah, that's quite interesting. Okay.
Yeah, and it could be because of the lower postprandial free fatty acids, right? So
Yeah.
you would have hoped that all that would have translated to better neonatal adiposity. It's a little bit disappointing, yeah.
Yeah, but maybe they were more aggressive with the correction and the insulin dose, but we don't know exactly. Okay,
Yeah.
thank you. Thank you so much. So we have a few questions here. First, we are asked if a lady is being diagnosed with type 2 in the first trimester. What do you recommend, like a typical medication for those ladies with a new type 2 in early pregnancy?
Well, we recommend insulin. I think you know, most oral agents are not recommended in pregnancy, and most of these women do need really high doses of insulin. So we would put them on insulin right away.
And second question, is it safe to assume that pump versus MDI is equal or worse? Say.
Well, one thing that we used to encourage women to switch to pumps in pregnancy. Now, if they're doing really well, we don't necessarily do that. I think the data on the pumps in pregnancy is quite surprising.
Mm-hmm.
And I'm hoping that I'm hoping that by changing how we practice using the pumps in pregnancy, we can improve these outcomes.
Totally. Thanks. And we often suggest to type 1 to bolus themselves 30 minutes before meals or 45 minutes before meals to help with the surge postprandial. Do you think that this could be recommended for certain GDM and type 2s also?
Definitely in type 2s. I think if you see hyperglycemia and then hypoglycemia, I would recommend for type 2s to pre-bolus as well.
It's a case by case.
Yeah.
Yeah. We have a question about COVID screening and GDM. What's your preference? Is it to use A1C and random or A1C and fasting blood glucose?
Well, this was highly debated. You know, fasting is probably better, but one of the people on the committee thought that it would be too hard to mandate the women coming in for fasting glucose. And that's why we didn't choose fasting glucose. But I think if the woman could come in fasting, it's probably better than random, yeah.
Yeah. Another question about early screening in first trimester. What would be your recommendation? Like A1C, fasting, or OGTT? That's a difficult one also.
Yeah. Do they have for GDM or type 2 or just?
For GDM. For GDM.
Oh, for GDM. Well, first I would do an A1C to make sure they don't have undiagnosed type 2. And, you know, depends. I think if we didn't have COVID, I would say do a GCT or an OGTT, depending on their risk. Even though we're not sure of the guidelines to the OGTT, I still would use the usual ones and hope for more research. During COVID, it's difficult. I think you have to just weigh the risks and benefits.
Totally.
And I would, if I saw an A1C of 5.9 or more, I would treat.
Right away.
Yeah.
Do you use metformin in type 2 during pregnancy?
Well, I'm gonna save that question for when the mighty results come out, which hopefully will be soon.
So we have to wait for the October meeting, right? Hopefully.
Well, probably the results will come out before October, but yeah, we'll hopefully present those in October.
Perfect. 2 last questions. Almost one. It's already run. Sorry. Would you? Okay. Yeah, which timing for type 1 is better, do you think, for switching MDI to pump for type 1? Is it preconception, early pregnancy?
Right,
Yeah, the
that's a
timing
great question. Of course, if you can do it preconception, that's probably the best time to do it. I have some patients who want to do it in pregnancy, and we generally do it after 12 weeks, unless the patient's doing terrible. But you know, if they're doing okay, we don't want to rock the boat because there is a little bit of, you know, getting used to the pump. So either preconception or after 12 weeks, preconception is probably the best.
And one last one, have you read anything about protein and large for gestational age baby? Like the amount of protein in diet, what's the correlation, or, you know?
Yeah, no, that's a great question, but I really haven't seen any data on it.
There's not much. We need nutritionists to help us with this topic. So thanks so much. This was very, very instructive, Denise. We will have to end the session. Thanks to everybody. I just have to remember that we're gonna have an annual meeting for the Diabetes Canada. It's gonna be a virtual meeting in October. So the program we're working hard on the program. So hopefully we're gonna be able to launch this very quickly. And don't forget to renew your membership to Diabetes Canada. And when you do so, you can add to be also a member of Candid. So by a $10 fee, you can add your name on our member list of the Candid and the chair. And I'm trying to have this team to exchange on the different hot topics in diabetes and pregnancy. Each year we have an annual meeting also and a debate. So hopefully we're going to see you in October for this little reunion with the Candid member. If you already are a Diabetes Canada member and you want to be also a Candid member, you just have to call Diabetes Canada to add this membership to Candid, and this is by dialing 1-800-BENTING. So, or online, you can check that. And thanks to Diabetes Canada, who made this talk possible. Each year, Diabetes Canada ease the life of our diabetic patients. So for sure, they would help a little donation if at a certain point to continue their great work. So thanks again, Denise. Thanks everyone for attending, and see you soon, hopefully.
Yeah.
Bye-bye.